Patients come in and their blood pressure is like 170 over, 100, and they're like, I feel fine. If someone feels fine, why should they care about their heart health?
Yeah.
And we're like, yeah, that's why they call it the silent killer, because, it increases your risk of heart attack, stroke, and heart failure.
Cardiovascular disease is the most common reason people die worldwide. We know very well that stress contributes to increased heart attacks. I think that's pretty well delineated.
What symptoms should never be ignored, even if they come and go?
I liken the heart to like the engine of a car. So if you've got a Ford, a Chevy, a Honda, and you're running on 4 instead of 6 cylinders, the most common thing that I hear of what turns out to be true pathology is, Doc, I used to be able to do something and now I can't.
All of these things that you may just think are the symptoms of getting older, but in reality are underlying cardiac pathology.
It is well known that the relative increase, the probabilistic increase of having a cardiovascular event goes up when those risk factors go up as well too.
That's right. So if we can get you in the office so that we have the opportunity to treat you, we can maybe mitigate that problem before it even happens. Hi, and welcome to Pulse Check. This is the podcast for Carolina Pines Regional Medical Center. I'm your host, Mark Stellingworth. I'm a local cardiologist, and I'm here with my colleague, Eric Bonno, who is a new cardiologist here in town. You've been here for 6 months?
6 months, yeah.
That's right.
Yeah.
So today we're going to take an opportunity to discuss some of the questions in the community that were posted earlier this week, and hopefully we can try and do it with some straight talk and less jargon and more truth. So it's all about heart health today. But before we get started, Eric, you went to school at MUSC for medicine.
Yes, I'm born in I'm South Carolinian, and I went to medical school in Charleston at the Medical University. Went up to Boston for my internal medicine residency. Came back to South Carolina, did my fellowship in Charleston as well.
And then you worked briefly in Greenville, and you came down here about 6 months ago.
I did. I'd say about 9-10 years in Greenville. I was practicing cardiology, and then came here about 6 months ago. Yep.
Okay. So we're going to talk a couple of questions, as I said before. So first bucket is going to be about risk factors and prevention. We're going to do another thing about, is this normal? And then bucket 3 is going to be symptoms and red flags. And then finally, we're going to talk a little bit more detail about heart attacks and heart failure and things like that. Sure. So first question that comes from our community is, if someone feels fine, why should they care about their heart health?
Yeah, it's a good question. It's kind of like you could always sort of colloquially say you don't judge a book by its cover. I mean, people externally can look fine, but what you don't see on the inside is atherosclerotic plaque building up, or hypertension, or any of the or really frank high blood sugars and things like that. So people can have risk factors and still look well. And so it's sort of hard to know just by judging a book by its cover. So
what's the difference between the modifiable risk factors and the unmodifiable risk factors?
Yeah, I would say the most unmodifiable risk factor out there is your genetics. That's, what mom and dad, brothers, sisters, what you were given at birth. And that's in my opinion, as the further I go in my career, frankly, I think genetics actually has a lot more to do with our overall health and what type of diseases we develop over time than there's a significant amount of modifiable risk factor contribution to cardiovascular disease. Matter of fact, I want to say I've read out there's statistics like a significant proportion, like 70-80% of heart attacks, heart failure, things like that are due to modifiable risk factors, right, of hypertension, diabetes, cigarette smoking, cholesterol, and so forth. But I think it's still important to understand that if your family has lots of cardiovascular disease, that still sets a milieu, a genetic sort of predisposition towards cardiovascular disease. I like to liken a lot of what we do is similar to there was theories years and years ago developed in the cancer field of what's called the 2-hit mechanism, that human beings have a genetic predisposition, or they are the fabric of their body, and who they are is determined by genetics. So that's the first hit, that if you have a predisposition towards something, okay, but then what you expose yourself to or what you are exposed to in your life is what then develops disease.
Sure.
And so I think that 2-hit mechanism works for cardiovascular disease. It's really really first sort of developed in cancer, but I think it works in cardiovascular disease as well too.
So circling back around to like the modifiable risk factors. So there are some things you can't avoid, like getting older, hopefully, right?
Yeah, exactly.
And being a man is one of those risk factors. And then there's things like family history.
Sure.
And so when we specifically talk about family history, what are we talking about?
Yeah, so a lot of times I like to ask all my patients about their family history.
Right.
So early, I remember in medical school, it was sort of, cardiovascular disease developing before 55 or 65, I think, in men versus women. Frankly, I just in broad brushstrokes, I just ask, what kind of cardiovascular diseases happened in your family. Now, I do tend to differentiate. If your dad had a heart attack at 95, well, okay. I mean, that's age related.
Right.
If your dad started having heart attacks in his 30s or 40s, that's really significant. Cardiovascular disease in general, I often liken it to sort of an age related, or people that are, as we get older, that's a little bit higher risk for cardiovascular disease. And I think we start to see that in 50s, 60s, 70s, maybe 50, 60 even being a little bit early.
Right.
People start to get, another way of phrasing this is that, if a person does everything right, and then they start getting heart attacks in their 80s and 90s, is that really something that they did, or is it really something that they're the risk factors? No, everybody's got to go with something.
Right.
And unfortunately, cardiovascular disease is the most common reason people die worldwide. And I think if you live to a certain age, it's not necessarily that you didn't take good care of yourself. It's the fact that human beings are just not made perfect.
Built to last.
Yeah, they're not made
forever.
perfect, and they're not built to last. And so something gets everybody. And so when patients tell me, oh yeah, my dad had a heart attack in my 80s, mom had a heart attack in her 90s, I say, well, that's not really, in my opinion, genetic. That's just age related. But typically you start having heart failure, arrhythmias, coronary artery disease, or other types of cardiovascular diseases, definitely in your 30s and 40s, and probably in your 50s too. That's starting to get kind of a little bit early. 80s and 90s, that's probably more age related. What do you think? Is that fair to say?
No, I agree with you 100% on all that. But so what, it kind of goes into our second question is like, at what age should people really start paying attention to their heart? And that really does depend on their genetics, right? If we're really going with that two-hit hypothesis.
Sure.
So, if a 20-year-old comes in and they say, hey, I'm having this chest pressure and it comes and goes, maybe at rest or exertion, and it's sounding kind of has like these atypical features, but then they say, yeah, but my dad had a heart attack at the age of 35. You're probably going to look at that person a little more systematically than somebody who is 20 years old. And they're like, yeah, my great grandfather had a heart attack at 95.
Yes. Perfect.
So it's important to prioritize the first degree relatives, right?
Yeah.
To see like mom, dad, brothers or sisters, do they have heart disease? And if those people have a early predisposition, then I feel like we need to get a little more aggressive. And that's, we'll talk a little bit more about like, is it anxiety? Is it real chest pain? And sometimes, if we, somebody can come in with like exercise intolerance or maybe palpitations, and they don't have a classic psychological trigger, we'll be more likely to systematically evaluate them if they have a family history or other risk factors that predispose them to heart disease.
Yeah, absolutely.
Do you agree?
Yeah, no, absolutely. Yeah.
Okay.
People have early onset legitimate heart attacks and things like that in their 30s and 40s, then that to me means your family, I think, is at risk of it. One thing I think becomes a little bit more difficult though, when just off the cuff here, what becomes a little bit more difficult is when patients say that their family members died suddenly. Because that almost inherently, people always think, oh, it must have been a heart attack. And people can have brain aneurysms, people can have a pulmonary embolism, people can die suddenly for a lot of different reasons. So that one becomes a little bit more murky, that I always have a little bit more fun teasing out in my mind with. But things like, dad got a stent in his 30s, like that's pretty young.
Yeah, sometimes when we have patients who are coming in with they've had an episode of syncope, one of the things I'll always ask them is like, do you have a family history of sudden death? And I like somebody below the age of 40 who just like all of a sudden just died. Yeah. And if they do that, then my index of suspicion is raised.
Goes up higher.
I'll be a little more systematic when I'm evaluating them. Yeah. If they don't have that, they'll still merit investigation, but maybe not to the same intensity.
Sure, absolutely. Yeah.
So, what about things like sleep and stress and lifestyle? How do those, that goes on to that second hit hypothesis part. Sure. So what are the things that you think about when, in terms of stressors for that?
Yeah, I think there's a very well delineated pathways between your mind and your body. In fact, there was not long ago a pretty comprehensive JAK article that I was reading about this, that the pathways between your brain, your nervous system, and your heart, and the rest of your organs are very it's like a two-way highway. And for sure, I think we know very well that stress contributes to increased heart attacks. I think that's pretty well delineated. How to measure that, how to quantify that, I've always found that to be harder.
Yeah, that's really difficult.
That's harder to say, like, okay, well, how much stress and whatnot. That's harder to know. But sometimes I will ask patients, if patients bring it up on their own. Matter of fact, I saw a patient here in the past week who was having chest pains, and he's like, I want to retire in the next few years because I'm on call all the time, and without giving out any patient information, but he was just like, I'm on call all the time.
Come on,
like, no, but I think that yes, that absolutely plays a role into it. And then I'll tell this to patients as well too, how to fix that. That's even harder.
Yeah.
How to quantify it is a little bit hard, but then how to say, well, because patients were stressed for lots of reasons that, frankly, as a heart doctor, there's things that you and I just can't fix in patients' families. And, there are things like, relaxation techniques, yoga, counseling, cognitive behavioral therapy and those types of techniques, and then along with pharmacotherapy, if people have significant anxiety or depression, that those can be helpful as well. But yes, I think it is pretty clear that stress is a cardiovascular risk factor. It's a little bit harder to quantify than getting an A1C or getting an LDL. But I think it is there. And then how to fix it, how to, I think that's up to the individual of how to find peace and how to find calm at the end of the day.
Right. So I think the trial that you're talking about is the Inner Hearts trial, which was looked at all the different levels of psychological stress. And they found it was that psychological stress was higher usually in younger women, but it progressed over time, in both sexes. One of the things that I sometimes use as kind of a surrogate for that is sleep. And, the recommendation is currently like if you at least 7 hours of sleep is probably the sweet spot for people to reduce their physiological stress. And if you're under 6 and if you're over 9, I think that argues for some psychological stress that could be predisposing you to coronary artery disease. So one of the things I always check on is sleep. So that's another good one. Yeah. This is an interesting question. And one I was like, well, I think the answer is, well, I'll tell you what my answer is, but let me see what you think. When it comes to heart health, what matters more, diet or exercise?
Yeah, I would say that is a bit of a tough question. I would say probably equal.
Yeah, I was going to say both. I was like, yes to both. Yeah, that's exactly
that's like saying, does my car need gasoline or does it need oil? It's probably not that you can separate the two or that one is more important than the other. I would say you have to sort of focus on both and keeping your body active for many, many, many reasons.
Right.
Not just cardiovascular health. I have a saying I tell patients all the time: when you stop moving, you stop walking, you start dying.
That's right.
And unfortunately, the worst case scenario, that being bedbound. That's just very badly prognostic. But moving your body and moving it to a great degree is very important for many things, not just your cardiovascular health, and then diet as well too. And that I find diet becomes really difficult in this country as well too. It's loaded down with everything and the things that we eat. So that's an excellent point. But I do say that the best kind of medicine is usually exercise. Sure.
But I think that there is also a lot of stuff that says like diet, like specifically things like the Mediterranean diet or the DASH diet. Both of those have some significant benefit. Yeah. But what do we characterize as like significant exercise? Is it like, does it have to be super intense, or can it be?
No, I think moderate. I think guidelines mostly recommend 150 minutes per week of moderate intensity.
That's right.
If I'm not mistaken. So I think probably I would tend to favor aerobic exercise more so than strength training, but I think either can be beneficial in their own right.
Yeah, and there is some benefit to like strength training for like bone density and things like that. Exactly, but if we're talking specifically about cardiovascular health, I think you're right. I think that probably the getting on the treadmill or doing some kind of aerobic exercise would be beneficial. Okay, so we talked a little bit about like we're going to move to bucket 2 here, and so how can you tell the difference between anxiety and a true heart problem? That's I'm like, well, you need context, really, right?
Sure.
So
I will say I tell patients a lot. I don't frequently come down on the diagnosis of anxiety. I don't really frequently say, oh, you just have anxiety, and it's mainly because as a heart doctor, we really can't be wrong. We can't sort of just say, oh no, you're just having anxiety and not sort of look into things. Can anxiety create chest discomforts? Yes, absolutely. That goes back to the psychosomatic sort of manifestations.
Right. Yeah.
But I think from my perspective, I'm very hesitant to call something anxiety until I know. And I think you have to be you have to be looked into, I think.
Yeah.
And so typically if somebody's experiencing chest discomforts, I first in my mind think, what is your pre-test probability that this is significant cardiac pathology? And that's based off of risk factors, age, the characterization of the discomforts.
Right.
And then you have to obtain objective data, EKGs, cardiac biomarkers like troponins or BNPs and things like that in the acute setting. And so we use, cardiac biomarkers to rule out and serial cardiac biomarkers and EKGs to rule out acute myocardial processes. And then once those are either ruled in or ruled out, obviously if it's ruled in that you're having an acute heart attack, a heart event, then you go down that pathway of therapy. If an acute sort of cardiac event is ruled out, then, it doesn't necessarily mean that you're not having some degree of ischemia. You could be having ischemia without infarction. And
Right.
that's where something like a stress test or would come into play in echocardiography.
Right.
I don't sort of usually call things just anxiety until people have sort of been proven to say, you're not, this is definitely not your heart by some objective measures.
Yeah. When patients come in to me and they're talking and they're like, well, I don't know, doc, you think this is anxiety? I tend to agree with you. It's like, well, it could be anxiety, but I also see it as an opportunity to risk stratify
Sure.
that person.
Yep,
because we're not only treating the person they are now, we're going to be we're treating the patient they're going to be 5 years or 10 years from now. So we want to, even if, let's say, they rule out with the stress test and their echo looks good, but they're overweight, maybe it's an opportunity to do a home sleep study to prevent them from developing, atrial fibrillation or other things like that. And maybe we can get their cholesterol under better control or more aggressive with their blood pressure, which, the classic thing is, I don't know about you, but when, your patients come in and their blood pressure is like 170 over, 100 and they're like, I feel fine.
Yeah.
And we're like, yeah, that's why they call it the silent killer, because, it increases your risk of heart attack, stroke, and heart failure. We really need to get you down here. What's your goal for blood pressure, though? Is that?
Yeah, typically at least under 140 over 80. We always think about blood pressure as commonly thought of as this sort of this dichotomous variable of above 140 over 80 or 90 is bad and under is okay. But it's actually probably more so, I think the studies show more so it's like a linear variable in that the lower the better. Now, obviously you can't have patients in their, 70s, systolics of 70s and 80s getting dizzy and so forth. So the lower the better. Typically, if somebody is hypertense and we get them down to the 110s, 120s, I'm usually happy with that.
Yeah, that's basically in accordance with like the sprint trial,
exactly,
which that came out about a year ago that said that 120 over 80 is probably our best goal for most people.
Yep.
And then I think if in the lower threshold, if they're without symptoms, I think it's like 90 over 70 is the lowest you want to go, really.
Sure. Yeah.
Barring symptoms, of course. If you're feeling dizzy, or if you're going from a sitting to a standing position, getting dizzy, or you're bending over, maybe time to scale back on your antihypertensives.
Yeah.
Another question the community asks here: what are some symptoms that people worry about that usually turn out to be harmless?
One thing I've noticed a lot, especially with having gone from seeing mostly heart failure patients to now a lot more of a general cardiology practice, is palpitations. I think I've got a saying that if you put a patch monitor on 100 people, I would venture at least half of them will have some ectopy now and then.
Right.
A little bit of atrial or ventricular, isolated, A or V beats now and then that you can feel. I've felt, little palpitations in my neck, and I sort of have the knowledge that, okay, it was a little short run of an SVT, no big deal. But I think palpitations bother people because they may not know what it is and so forth. And a lot of times I'll put people on a patch monitor and find, oh, you're having a little short run of SVT, for 2 beats, 3 beats, and you felt it. That in most cases, sometimes I will get an echo to make sure that is not a manifestation of structural heart disease. But in many, many cases, I think it is within normal limits to have some small amounts of ectopy.
Yeah, I agree that the palpitations is always the most vexing.
Yeah.
And some of the things that decrease my suspicion is usually when they say something like, well, when I'm about ready to go to bed, I really start to feel them. I feel these extra beats. And sometimes I'm thinking, well, that could be your parasympathetic and your sympathethetic system competing. Maybe you're getting a little ectopy, you get ready to go to bed. It doesn't stop me from doing, the testing that you have recommended. But
well, one thing I try to differentiate is in the patient's history, is it sort of a little extra jolt that you feel maybe once or twice, or is it you're feeling your heart racing for like 10 or 15 minutes?
Right.
If there's a little sort of extra jolt, that's probably a PVC or a PAC, and that's probably a little bit more benign. That the caveat of that is if that happens really frequently, if you're having little extra jolts, PACs every few minutes or so, okay, that might not be totally normal, but a little extra jolt, a PAC, a PVC, and by that I mean a premature atrial contraction, a premature ventricular contraction, an isolated extra beat that people can feel and people can be bothered by, but in itself, if it's rare, it's to me is not in the setting of a structurally normal heart. That one is usually that turns out to a lot of times be nothing major.
Yeah, but I think if we take the 50,000 foot view on this, right, is that if you feel the symptoms are concerning enough that they bother you, we think it merits investigation.
Yes,
so you at least should talk to your primary care provider, and if they feel that it is something that demands our attention, then we'll do the workup. So I mean, I think it's best to have reassurance in that kind of regard. And so we may not be as if we do a short amount of tests and all those tests come back negative, like the echo and whatnot, then there's probably no additional workup necessary. You may not stay with the cardiologist for that palpitations, but you'll at least have a checkout and you'll have the confidence to know that your heart is healthy.
Yeah, and I usually mean that this, like when you arrive upon that after doing a monitor.
Yeah, exactly.
Because that's sort of my take is if somebody's walking in the door and they're taking time out of their day to go to see a heart doctor for it.
Oh yeah,
it warrants looking into because it could be AFib, it could be little short runs of NSVT, non-sustained VT, which is not normal to really have. That's what I mean is after looking into it, what sort of turns out to be nothing major. A lot of times palpitations. I think that's
Okay, the next one I have an answer for, but I want to hear what you have to say. At what point should someone stop Googling their symptoms and actually come see a cardiologist?
Oh boy.
How often should you rely on Dr. Google is what I'm asking Dr. Bonno.
Yeah, that's an interesting question.
My answer is never. I think you should probably, if it bothers you, quit Googling and start talking to your primary care doctor and your cardiologist if you have one.
I think that's fair. I think there's lots of rabbit holes that people can go down into on the internet and in their mind. And I think if you're worried about something the relative ease of getting an echo and a stress test, putting on a treadmill, whatever, if it helps me to reassure a person, then do it. I mean, I wouldn't go. I don't take stock in all this like going on Google and trying to diagnose yourself and stuff like that. If you're worried about it, just go get checked out.
Yeah, take the time to see an expert, and then at the very least, it'll be an opportunity for us to positively impact your blood pressure, your cholesterol, your diabetes, your weight, all of those other things. So mine is never.
Get off Dr. Google.
Get off Dr. Google.
Yeah, exactly.
Get off Dr. Google.
You heard it from us.
So bucket 3, symptoms and red flags. What symptoms should never be ignored, even if they come and go?
Yeah, that's a great question. So my standard spiel for patients is that I liken the heart to like the engine of a car. So if you've got a Ford, a Chevy, a Honda, and you're running on 4 instead of 6 cylinders, the most common thing that I hear of what turns out to be true pathology is, Doc, I used to be able to do something and now I can't.
Fatigue.
I used to be able to, exactly. I used to, and not even global fatigue, just, gosh, I just feel tired all through the day. What I call it is exertional intolerance. I think that's probably the most specific symptom that I hear of what truly tends to become what turns out to be cardiac or pulmonary pathology. Is I used to be able to get on the treadmill for 30 minutes and do great. And now, like, if I climb up a flight of stairs, I'm just winded. Like, it's weird. I'm getting really short of breath just walking up a flight of stairs. I used to be able to do that easily a month ago or whatever. So some degree of exertional intolerance is usually the most specific symptom. And that also goes with chest pain. Right. That's what we call classic angina, or what colloquially also people call angina, but angina is a squeezing sensation in your chest that occurs when somebody overexerts. It usually gives them pause, typically lasts 5, 10, 15 minutes, and usually eases off with rest. And that's an exertional symptom. And so it goes along with that is that heart-lung disease typically will create some degree of an inability to do something. And then similar to an engine in a car, you try to get your car up to 60 miles on Bobo Newsom. And if you're running on 3 cylinders instead of 6, it ain't going to go. Yeah. And it might do okay idling. Your car might idle well, but if you try to go, it's just not going to go. And I think that's sort of a good analogy.
No, it's excellent. What about are there any differences that you find between men and women when they come in with presenting with chest pain?
Yeah, that's an interesting question. I had this conversation with somebody not long ago. So studies do show that there is a relative increase in atypical symptoms for women. So men more classically clutching your chest pains. I do remember reading a while ago that there are more atypical symptoms in women in terms of nausea and fatigue and other sort of radiation symptoms, jaw, the arm, and things like that. And that's relative to men, but still on average for absolute numbers that women still that present with heart attacks still mostly present with chest pain.
Yeah. So if and the one for me that's always like, do not pass go, do not collect $200 is, I've got this chest pressure that radiates to my jaw.
Yeah.
Like anytime I have jaw and chest pain together, I'm like, this is not good.
Yeah.
And
jaw gets my attention.
Yeah. That's always something, but there are, like you said, there are these exertional symptoms, this exercise intolerance, all of these things that you may just think are the symptoms of getting older, but in reality are underlying cardiac pathology that need, a structural evaluation or a structured evaluation. So,
and then what happens as well is that patients will then start to normalize not doing as much. So then they
self-limiting.
They start to self-limit and then they just, So
we see that a lot with valvular disease.
Exactly.
Right?
Bingo. That was the cardinal thing, aortic stenosis.
100%. So the aortic valve doesn't open correctly. It compromises the cardiac output of the ability of the rest of the body to perform. And so people, instead of walking up the stairs, they'll take the elevator. Instead of cutting the lawn, they'll start gardening and things like that. So,
but then it gets confounded because then you say, well, are you getting short of breath? Are you getting chest pain? No, I'm not going to. It's because they're not doing as much. Right. So exactly.
Right. Self-limiting is the bane.
I'll tell you another one, Mark, that gets me too. Or I always think about it, take it a little more serious, and I've seen this a little bit more as my career's gone on in acute MIs is arm pains, bilateral elbow. I've had patients I just had bilateral arm numbness and tingling in my elbows where that's always a little bit of an interesting symptom is when people just have arm pains.
Because the classic symptom is like, doc, when I exert myself, I get the substernal chest pressure that radiates down my left or right arm. Usually it's the left arm. It's associated with either nausea or vomiting, maybe a little sweating, and it goes away with rest. And then if that becomes more frequent in terms of its intensity and the duration of your activity becomes shorter and you get this, then it's like, okay, you're getting closer to a bigger problem here. So we need to get you in the cath lab or get you at least a stress test. Okay. So bucket 4 is the unspoken fears. What does a heart attack actually look like in real life, not just on TV? So when you watch ER, do you sit there and be like, that's not what a heart attack looks like. That doesn't look like it.
Yeah. I mean, I think the most classic symptom is chest discomfort, chest tightness, but I remember watching Sanford and Son many years ago, and the father clutches,
Red
Elizabeth,
Fox.
I'm going, Red Fox,
Yes.
I'm coming, and and that may not, it may not be that dramatic. I mean, sometimes people may come in and they have high troponins and they have some symptom that prompted them to come in, but an acute heart attack may not be that they're crashing and burning. It might be that they just don't feel well and they don't, they can't exert without chest discomfort, and they may not be crashing and burning and dramatic, but there's still ongoing ischemia and damage to their heart. I'm not sure if that helps answer the question or.
I guess there's really no classic presentation there, but there are things that are red flags for us that we think about, but we also have a pretty low index of suspicion because we've seen such variegated forms of chest pain and acute coronary syndromes. And heart attacks can feel different to different people in different ways. I was in the emergency room just about 2 weeks ago, and there was a guy who had just recently started resuming exercise. He'd been very active before, stopped for about 3 months. He started doing bench press, and he had done this bench press, about 3 days earlier, and then he had this really bad chest pain, and it was across his chest. And he had just attributed it to, well, I'm just out of shape, and I hadn't been doing anything. But then he had the syncopal episode, and then he comes in and he's bradycardic, and his troponins elevated. So I took a look at the guy and saw this whole thing, and I said, well, this is probably a right-sided or a right coronary artery infarct because his heart rate's so slow and all that other stuff. So we ended up taking a look at his coronaries, and sure enough, he had a blockage. So that you can have these very unusual presentations. So you have to you have to be kind of vigilant when it comes to that kind of stuff. If it's enough to give you pause, then you probably need some talk to a professional.
Sure.
I think that's probably the safest way to describe it. But what exactly is a heart attack? I know you gave a great acute coronary syndrome talk just recently.
So heart attack is, to me, whenever patients say I had a heart attack, I always try to press them a little to say, heart attack is a colloquialism. It's what the layperson says. Cardiologist tries to be a little bit more accurate. The most, what most people colloquially call a heart attack, a cardiologist would probably more accurately say a thrombotic occlusion, meaning a blood clot occlusion that occurs in a coronary artery and disrupts blood flow to the distal muscle bed that relies on that artery. A type 2 MI, essentially, that a blood clot forms. Type 1, excuse me.
Type 1, that's right. Type 2 is demand. That's right.
Excuse me. So that, I think that's what most people sort of call a heart attack. But, people also say if somebody had VT because they have heart failure and they collapse, and some people say, oh, that was a heart attack. Well, anyway, so I just try to be a little bit more sort of specific in what the event was and what the pathophysiology was. And I think heart attack in general, typically when people say that phrase, that colloquialism, I think it mostly refers to a type 1 MI when you get an acute blood clot in the coronary artery, most commonly because of an underlying atherosclerotic plaque in which the endothelium denudes, meaning that the skin overlying a cholesterol-laden plaque becomes disrupted. It becomes like a cut on your skin on the inside of the artery, and then your body tries to heal that over with first a platelet plug and then a thrombus that then can propagate to occlude the entire artery.
Right. And
I think that's what we sort of call a heart attack. Best treated with things like blood thinners, anticoagulants, and if it gets within a stent, coronary angiography, stenting, et cetera.
Right. So one of the things, we'll have patients who will come in and say, yeah, I had a heart attack 30 years ago, and they're 50 years old, and you're like, that would seem kind of unusual for a 20-year-old to have a heart attack. And then they say, well, and then we ask, the next question I usually ask them is, well, did they have a stent, or did you get a stent or something? Yeah. No, I didn't get a stent. So then I start thinking, okay, well, maybe there are, so there can be things like, heart failure itself can cause a bump in your cardiac enzymes. Profound anemia can do it. Oh, yeah. Profound hypertension. Patients who have kidney disease, who, they all of those things, while are not excuses, there's still possibilities that that could be causing something that looks like a heart attack, but really isn't.
I think what you're also getting into, Mark, is that in today's era, we diagnose heart attacks very commonly with blood enzymes, with cardiac markers called. And in the old days, it was a protein called LDH, a molecule called LDH, and then it was the CK, and there's just different proteins. Today's era, we diagnose heart attacks most commonly with a blood protein called troponin, which is a component of the heart muscle that is not supposed to be found in your peripheral blood, and it really should just be located to your heart. Unfortunately, fortunately and unfortunately, troponins have become so high sensitive. They've become so sensitive, our ability to detect troponin in peripheral blood, that they become positive even in patients that are not really having an acute coronary or an acute cardiac syndrome. So, for example, someone has bad diabetic ketoacidosis, or they got pancreatitis, or they fell off a roof, or sepsis, or anything that sort of induces inflammation and strain on the heart can make your troponin go up. Now, it may not go up to the degree to which if you occlude a coronary artery, but those positive cardiac enzymes then very commonly equates to the patient saying, oh, I had a heart attack. And frankly, because a lot of times doctors will tell them, oh, you had positive troponins, you had a heart attack. And in fact, it had really nothing to do with their coronary arteries, but that's what gets muddled and that's what our job a lot of times is to figure out. But that becomes, I think, a little bit more murky too. And people say, oh yeah, well, I was intubated because I had a massive PE and I had a heart attack and they say, well, you had positive troponins in your blood. You didn't have what I would traditionally call a heart attack of an acutely occluded coronary artery.
Yeah. So just to reiterate that, the coronary arteries there are basically three arteries that supply the heart, and those are called, they sit on top of the heart like a crown, hence the name coronary arteries. And when those things get blocked, we say that's most likely a heart attack. Yeah. Now they can get partially blocked, and that's what we call a non-ST elevation MI, and then they can get completely blocked, where that clot goes all the way and it blocks the whole vessel, and that's called a STEMI. And the STEMIs are usually an acute emergency, right? And we need to send them somewhere to get stents and get that taken care of. And then the non-STEMIs still may need stents, but it's not as urgent. They can get those within 72 hours or so. Yeah. So, so if someone has risk factors, does that mean they're absolutely going to have a heart attack?
Not necessarily. I think that probably goes out along with the two-hit mechanism. I would say it's sort of akin to when you hear a patient say, well, my dad smoked all of his life and he never got lung cancer. Well, yeah, that is true. You have risk factors and you never develop heart attack. That's true. It's still not good to smoke, and it's still not good to have all these risk factors because it increases your predisposition towards something. And in our field, in our world, Mark, nothing is absolute. We always talk about probabilities, and it is well known that the relative increase, the probabilistic increase of having a cardiovascular event goes up when those risk factors go up as well too.
That's right.
It's not to say that if you live all your life with an LDL of 220 and a blood pressure of 180 and an A1C of 9 that you're absolutely going to have a heart attack and develop heart failure. It just means that your chances of developing those are much higher than people that don't have those risk factors.
Yeah. So in a phrase, ignorance is not bliss here, right? So I mean, it's important that again, if we can get ahead of the problem, get ahead of the pathophysiology, we may be able to prevent something. And that goes to our newer technologies, things like cardiac MRI and cardiac CT, where we can look at plaque composition and see if there's something that we can address before the heart attack actually occurs. And there's new data that says that if we lower cholesterol below certain levels, we can actually see some plaque regression. So if we can get you in the office so that we have the opportunity to treat you, we can maybe mitigate that problem before it even happens. So
it's funny. I've read hundreds of years ago, the most common reasons for death were trauma, accidents, infectious diseases, and things like that. Cardiovascular disease, the rise of cardiovascular disease over the last several hundreds of years, you could sort of perceive that it, as infectious diseases have been addressed with vaccines and better cleanliness and more advances in society, that we're now dying of degenerative diseases, that we're living long enough to degenerate and see the effects of eating other animals. And, plants don't really have a lot of cholesterol. If you eat nothing but plants, your cholesterol typically doesn't go up much above beyond what your genetics would dictate. Right. But eating other animals and eating all this processed stuff, I mean, I don't think in the centuries past that people had the degree of heart and cardiovascular disease as we do now in society, mainly because they were probably dying of other things and things like that. But it is thought, that they are degenerative diseases that we can prevent by and large.
Right.
And I forget the exact number, the exact statistic, but I have read that it essentially, they think that it's like a staggering percentage, like 80 or 90%. I can't remember the exact number, but that a lot of cardiovascular disease can be prevented. It's because of modifiable risk factors.
Yeah.
So it goes back to what we were talking about.
Yeah. So going back to like the Mediterranean diet, which prioritizes unsaturated fats like olive oil and things like that, portions control in terms of prioritizes vegetables, as you've just said, and minimizes the amount of red meat and the amount of and maybe fish and chicken are more of a priority. When you look at the DASH diet, it's more about 5 servings of fruits, 4 servings of vegetables, and then not low fat dairy products twice. And protein, again, if you can get it through the through other animals aside from red meat. So our dietitian over here talks about if it's on 4 legs it's bad, if it's on 2 legs it's a little bit better, and if it's on no legs it's the best. So having and you can also get protein through through vegetables, and there are obvious vegetarian diets, and if people want to take a look at that, they can do that as well. But I think that underlies the larger issue in society, which is about obesity.
Yeah.
And,
Absolutely.
and this, the success of the American economy has also made food affordable, but that affordable food is sometimes not the best for you. And so trying to prioritize those things that are healthy, heart healthy, can be more challenging if you're just trying to get the kids fed at night after a long day of work. So we understand that that's a struggle, but if you can prioritize that health, you can do yourself a long-term benefit. So the final question we have here is, can heart disease or heart failure be managed or even improved? So
yes, of course. Yeah. I mean, if heart disease could not be improved, we would be in bad shape. Exactly. We'd be out of jobs here.
Really
so of course, no. I mean, I tell every patient, my goal for you is to improve your heart. Is every patient going to get that? No, of course not. I mean, some people, it's just like every car engine out there is not going to be repairable.
Right.
It really depends on the degree and the duration and the degree to which pathology has set in. I mean, I can't tell you countless patients, you and me both, that your heart looks like that on diagnosis and it looks like that a year later or 6 months later. That's medical therapy or special types of pacing modalities or revascularizing with bypass and whatnot. So I mean, yes, that's always our goal, is for things to improve. Is there a proportion of patients that will never get better no matter what we do? Yes, of course. Unfortunately, that is true.
But that proportion, I think, over time has gotten smaller and smaller in our careers. We've had, just recently. Well, if we take a grander view here, before your time, and probably when I was a resident and a fellow, we were really working on addressing coronary artery disease, getting those stents in as fast as possible, maybe even using thrombolytics, which are clot busters, but we don't use those as much anymore. And then once we got those stents in, how do we keep them open? Yep. How do we protect the patient? How do we maintain their quality of life? And we were extremely successful at that as a nation and as a medical community. But now we're dealing with the consequences of our success, and we're dealing with heart failure, where people's hearts aren't as strong as they used to be because they have a scar from that heart attack. And so now, what are the medications and what are the devices that we can put in to actually make the patient's quality of life and hopefully their heart stronger? And then in the last, 8 years, I would say, we have a whole host of new medications, things like Entresto and all these other medications that have been shown to profoundly improve what we call the heart squeeze, or the ejection fraction of a heart. And that just by itself reduces the patient's risk for long-term cardiovascular events. So we're and the next step, is probably going to be something like, cardiac CT and cardiac MR, where we try to reduce the amount of fibrosis that we see in the heart. And can we get that cholesterol down so that those plaques that we see on the CT go away? All of those things are things for the future that we're excited about.
I was smiling as you were talking, Mark, because I remember an editorial, sort of a paper by Eugene Brunwald, who's a godfather.
The godfather of cardiology.
Brunwald, it was very, very succinctly put, probably better put than I'm going to say, but essentially the epidemic of heart failure that we're dealing with now is due to the success of coronary revascularization during acute heart attacks. That all these people that are living now long enough to deal with heart failure is because they didn't die during their acute heart attack. That quickly revascularizing people that would have just died, right? That now that we're sort of having an epidemic of a problem due to a success decades before. So I mean, I'd rather people be alive and have that problem, but
I think the things that we as a community of physicians want to do is really try to improve the quality of life for our patients. Sure. And we have a host of mechanisms that we can do that for. Yeah. And the challenge for us is figuring out when is the right time for the right thing. Yeah. How do we make, okay, they've got, a leaky valve. Well, does that leaky valve need to be fixed so that we can make their life better? When does it need to be fixed? And so our community is constantly refining our techniques and using new technologies. Things like, we used to have to do open heart surgery to replace valves, but now we have the ability to deliver stent type valves where we go in through the artery and we can open up that stenotic valve and we can clip that leaky valve. Our job is to stay abreast of the guidelines, stay abreast of those developments, and then figure out when we can maximize our outcomes for our patients. Yeah. So, okay. Well, listen, this has been a really great overview of cardiology. Eric, thank you for taking the time to do this.
Thank you, Mark, for having me.
No, it's no trouble. Do you have any other final points you want to tell the community? These are some good questions, though. I have to admit, I was like, wow, okay. So good job by you guys. Good job.
No kidding. I'd have to think about that.
Well, I think we kind of summarized a little bit about it takes a whole team, right?
Absolutely.
We are just one component of a larger community, and we're part of a community of physicians, but we're also in the community of Hartsville,
Yeah,
and how many patients have you seen when you're in Food Lion or when you're over it, and you're just like, and they're like, hey, Dr. Stellingworth, I got that ablation or whatever, and you're just like, oh, so I think that's one of the great joys of being here in Hartsville and being part of Carolina Pines Regional Medical Center is that we see the fruits of our success every day.
Yeah, absolutely.
At the ballpark, at the over at the grocery.
I've definitely noticed that. I was in a large practice. I had about 40 heart partners in Greenville, and it was a great job and great patients, and I loved it. But it was a 1,000-bed hospital, their flagship hospital. I was seeing lots and lots of people per day, the sickest of the sick, and the one thing that I sort of lamented that pushed me, contributed to my decision to leave a large practice in a larger city was feeling very, very disengaged and not knowing the patients, and that's not good.
Yeah.
In Hartsville, it's been very different. I've gotten to know people a lot better here, and everyone knows each other. It's been more satisfying, I think, in getting to know the patients here.
Well, I'm happy to say that their loss is our gain. And so I want to thank you, Eric, for coming out. And I also want to thank everybody else who provided all of the questions today. And those questions really helped guide this conversation. And hopefully we'll be able to do this again. So I'm Mark Stellingworth, and on behalf of Eric Bonno, I want to say goodbye and good luck.
Thanks for listening to Pulse Check. If you enjoyed this episode, be sure to like, follow, subscribe, and share it with someone who might find it helpful. Your support helps this podcast reach more people in our community. Pulse Check is a production of Carolina Pines Regional Medical Center. Special thanks to our producers Hannah Cadell and Anna Tingen. Audio, video, and editing services by Seth and Grayson Johnson at Lockwood Studios. All content is for educational purposes only. We do not intend for the content to be a substitute for professional medical advice, counseling, diagnosis, or treatment. Our content doesn't engage visitors into a professional relationship. We'll see you on the next episode of Pulse Check.